Cool. Well, I think we should get started. We've got about 25 people right now, so. Okay, welcome to our second online training session. Thank you to all of you for taking time out of your Easter Monday to participate in this session. Thank you to Dr. John Wallace for joining us and being the presenter. For those of you from Divisions Up Island who didn't tune in last week, my name is Anna. I'm the DS down here in Victoria. I will be kind of moderating this session. So what I will do once John gets started is I will make sure all of you are muted. And if you see down in this general area, there's a chat box. If you have any questions that come up while John is talking, you can type them in there and I'll be watching those. We will do a question and answer period at the end. At that point, if you have any questions that come up then that you'd like to ask, there are little icons down at the bottom. You can do a hand wave and we can unmute you so you can ask your question. Other than that, I can let John introduce himself and we can get started.
Great. Thanks, everyone. Thanks for having me. And yeah, this is a fun way to spend the quarantine here. So I've been asked to talk about pediatric patient assessment, which is a fun topic. For those of you who don't know me, I am the divisional, at least I still think I'm the divisional medical officer in Victoria, but I don't live in Victoria at the moment. I actually, let me get my my wand warmed up here. Well, that's not gonna work, hey? There we go. I'm actually working right now in Alberta in Crow's Nest Pass. And if you are like me from the islands, you assume that BC's all the mountains and Alberta's all prairies, but it's not. There's actually a thin strip of probably the highest mountains actually in the Rockies along the Alberta border. And so that's where I am. I'm about 8 kilometers across the BC border in Alberta. This is our hospital. This is the view as you walk out of the front door of our hospital. And in that big monolith in the background is Crow's Nest Mountain. So my job here is anesthesia and a bit of emergency medicine and all of the rural critical care. And so I get called for the sickest of the sick patients that we see in our little hospital. And so, you know, being able to assess kids is definitely an important part of the job I do. Not necessarily a huge part of it, but a very important part. So bear in mind that I am here in the Rockies and my internet connection is sometimes a little bit patchy, so apologies if I phase out here. I'm also on call 24 hours a day for anesthesia, so there's a very low chance that my phone may ring, in which case I will have to mute myself for a minute or two and then hopefully be able to pick up. Otherwise, we'll reschedule this for another time. So without any further ado, let's jump into the presentation tonight. So overview, what I want to talk about today is I want to introduce you to 3 acronyms, and 2 of them are not really that important. One is just a term, and one is a twist on a great memory aid that you know and is ingrained into you right from the first day you ever take a first aid course. And the last one is the important acronym to learn. So we'll introduce these shortly. And what I'm going to talk about is what is going to make kids so special as compared to dealing with adult patients. What is your first impression? How to make a good, valuable first impression. And that's where we're going to talk about this first acronym, the Pediatric Assessment Triangle. We're going to talk about how to make friends with kids, because if you don't have that parental or aunt or uncle experience in your life, or if you haven't had it for a while, sometimes you forget how to do these things. And there's some definite tips where you can establish that rapport much quicker, which really helps. We'll talk a little bit about history taking, and we'll talk a little bit about how to examine a child as well. All right, so let's just jump into this. So in terms of what makes kids special, there's a whole bunch of things. And in fact, you can spend 4 years of your life in a pediatric residency and learn all about them. But from the first aid perspective, I think the most important things to remember is that they have different normal vital sign ranges from adults, and it completely varies depending on the child. And so there are different memory aids to remember what, normal blood pressure is and heart rate and blah, blah, blah. Probably what's better than that, unless you're a full-time dealing with children, would be to get an app if it really matters. But, realistically at the MFR level, I think it's probably one of the less valuable ways to assess your child and reassure yourself. You should really be looking at other things. Nevertheless, you still take your vital signs, and so it's worth having a reference that you can look up. But there should be many apps free available on your phone for that. The next thing that makes kids different is that they're unable to provide a good description of what they're feeling. And if you have a 2-year-old or a 3-year-old, they are completely open to the power of suggestion. So, I just put my 3-year-old to bed, and I guarantee you, if I had asked her, does your nose hurt? She would have said yes. So just be aware that you can definitely implant these ideas. We sometimes in emergency medicine refer to pediatrics as veterinary medicine because you just don't get a history. So you're kind of basing things on what you can see, what you determine when you examine the child, and then you're basing it on what the parents are telling you. And often the parents are anxious, and of course they're subjectively interpreting it as well, which is good because it gives you a lot of insight you don't have, but it's bad because they aren't necessarily right. So you kind of have to weigh what they're telling you with what you're seeing and kind of find the happy medium in there. The last thing about kids that I want to touch on is that children, and I think we all know this, children tend to decompensate very, very quickly. So they look great because they compensate really, really well, and then all of a sudden they crash and they try and die on you. So that's not very good. So if you have a child who you're worried is seriously ill, you want to definitely act on that sooner rather than later and not wait for them to get worse. Adults kind of have this relatively slow decline over time, whereas children are much more crashy. Good. So next thing I want to talk about is how to tell if a child is sick or not sick. Excuse me. And by sick, what I really mean is unstable. So how do you tell if a child is unstable or stable? Kids are often anxious by nature. So just by virtue of bringing them into this bizarre environment like a hospital or a mobile first aid post, they're going to be anxious. As I say, young kids can't really describe what's going on. Parents do their best to interpret it. You get these vital signs that may or may not make sense. A lot of children won't tolerate a blood pressure cuff. So how do you assess them? And this is probably one of the best tools I've come across in emergency medicine. It's called the Pediatric Assessment Triangle. So this is acronym number 1, and you really don't need to ingrain this in your brain. It's merely just a term so that you can talk about this and everybody knows what you're talking about. So what this allows us to do is to assess the child by looking at them from across the room without having to get up in their face or touch them or whatever. So they may be in an odd environment, but their caregiver can hold them in their arms, and you can still get a very, very accurate assessment of how sick or not sick this child is by simply applying this little tool. So this is acronym number 2, the ABCs, which we all know and adore, but it's got a slight twist to it. So we have breathing and we have circulation, but A is different in this context. It stands for appearance. And we're going to go over each of these 3 parts in turn here. So for appearance, the acronym to remember, and this is the 3rd and final acronym I'm going to throw at you, and this is the one to remember. It's the TICKLES acronym, spelt in a very elaborate way, kind of like how my 3-year-old would try and spell tickles, I think. No, wait a minute, she wouldn't be able to do that. Maybe how my 5-year-old would try and spell tickles. So what TICKLES stands for is tone, and by tone, what we're talking about is muscular activity. So children, by nature, move a lot, and that includes the day they're born. We actually did a C-section this morning, and so we had this baby on the warmer who was about 30 seconds old, well, maybe 60 seconds old, and she was already like beginning to spontaneously move her arms and legs. And so it's really looking at the strength of that. If you have a child who is floppy, that's a bad thing. So so the T in TICKLES is for tone. The I is for interactiveness. So once you get over a certain age, and I'm going to say probably around sort of 3 to 4 months, kids really begin to be aware of their surrounding, and they begin to interact with it in whatever age appropriate way. So for example, a 6-month-old, I can take a pen light or a stethoscope and I can swing it in front of them, and they'll look at it and they'll watch it. And as they get a little bit older, they'll reach out and try and grab it. And of course, older children will actually be aware of what's going on, looking around the back of the first aid post, asking questions and whatnot. So they're interacting with their environment, and that is reassuring. This is what a normal child does. It's annoying as heck when you're a parent of multiple toddlers and it's nonstop. It's like a 18-hour-a-day affair, but it's a very good sign that the child is healthy and they're doing well. Their brain's well perfused. So interactiveness is the I. C is for consolability. And so a child who is well will typically cry and be anxious, but when their caregiver picks them up and gives them a cuddle or gives them a pacifier or soothes them, sings to them, they will calm down relatively quickly. Whereas a sick child is not going to do that. They're just going to cry listlessly. They're never really going to settle despite the best efforts of the parent, which of course leads to this whole anxiety in the parent, which I was talking about before as well. So if a child is freaking out because they have been dragged into this first aid post, and the parent picks them up and puts them on their lap and gives them a cuddle and they kind of settle down, that's what you want to see. If they're not doing that, if they're just wailing like there's no tomorrow, then that's a bad thing, and you need to be worried about that. L is for look, and that's in terms of their eye contact. So again, once the child is, gosh, like maybe 2-3 months, they will begin to, maybe even younger than that, they'll begin to track things. And the parents will definitely know what's normal and what's not for their child. And so if you have a child who is watching as you bring that pen light close or you bring that stethoscope towards them and they're tracking it, then that's a good thing. If they're staring off into space, looking through the wall as if you're not even there, that's a bad thing. So we talk about look, making eye contact, actually tracking things for older children. We talk about gaze as the term for younger children. And it should be there very, very rapidly. Like, as I think about it, probably within the first few weeks of life. Probably Linda will be able to guide us a little bit more on this, because if I remember correctly, she has a lot of pediatric training as well. Now, speech and cry is the final one. And so when a child speaks, just like when an adult speaks, you expect a certain normality to the voice that they're making. You don't want the hot potato voice. You don't want stridery, whatever, all the stuff that we talk about in first aid. So children generally begin to speak around a year or so, starting with words and whatnot. If they're younger than that, you assess their cry. So are they having a normal cry? Does it sound normal to the parents? The parents are your touchstone in that regard, because they'll be able to tell you what is normal, what is not. So this is the tickles mnemonic. This is what you think about under that appearance subheading when you're doing your pediatric assessment triangle on these children. If any of these 5 things, or if any of these things that we're going to talk about in breathing and circulation comes back as a red flag, you have a potentially sick child and they should be transported sooner rather than later. Okay, so that's appearance. Now we're going to move on to breathing. Now, we talk about worker breathing a lot in first aid, and there's a lot of descriptors that we can talk about. So I'm not going to bother belaboring this and reading out everything that's appearing on the slide here, but again, these are all the things we're looking for. And what I typically do when I have a child is I will ask the parent to take the shirt off so that I can see what's going on, right? Now, obviously, I'm talking about younger children here, not children who are approaching puberty. And we need to do it in a careful manner where we're not doing it in the middle of a field. Probably better to do it in a more private first aid post setting. But these are the things that you're looking for. So hopefully these are all fairly self-explanatory, and certainly if you see anything here, we need to be thinking about shipping these patients. And then next is circulation. And again, we talk about these things in first aid, and it's really not any different for kids than it is in our in adults when we do all of our first aid instruction about the signs of shock. So we're looking for various changes to the skin and the mucous membranes. So if the child is ashen or pale, pallor is present, we need to be worried. If they have mottling, meaning you have kind of those bluey, patchy areas in the limbs, that's a problem. And of course, cyanosis, we all know and love what that is. And we need to deal with that immediately as well if there's a child displaying those symptoms. So that, in a nutshell, is the pediatric assessment triangle. So remember, the twist to that is appearance, breathing, and circulation. And to remember what you're looking for with appearance, you have the tickles mnemonic, the tone, the interactiveness, the consolability, the look or stare, or the look or gaze, and finally the speech or cry is the fifth component. Good. I'm going to just power through this and then we'll have a group discussion. So how to make friends with kids. What I find is that kids are shy fairly consistently, age 4 or lower, but it depends on the child. And sometimes you have teenagers who are crazy shy as well. And so, this first tip works, I think, best with younger kids, not the maladapted teenagers who can't interact with adults. What you need to do is ignore them. I basically allow the child to hide behind the parent and play their game. Sometimes it's playing a game, sometimes it's a natural reaction. And I just talk to the parents as if the child's not there. And sometimes, if you use the child's name enough, human beings cannot ignore their name. And so you'll see them inevitably peeking out, looking at you, and they sort of come out of their shell to try and see what's going on and why you're talking about them. And so at that point, I will sort of lower myself down to the child's level, if I'm not already there, and I will talk to them about stuff that matters to them. And this is where it really helps to know about, the most common cartoon characters and things like that. And fortunately, they don't change over that quickly. So if you know who Dora the Explorer is, and if you know about Paw Patrol and can name one of the pups, and it's a Disney princess or two, I think you're pretty much good to go. It's also a great excuse as an adult to watch some of these things, because a lot of these shows are actually kind of fun to watch in small doses. And if you're able to comment on the fact that this child has, like Thomas the Tank Engine on their shoe, and talk to them, they kind of begin to trust you. Because if this adult knows, the finer points of the shows that they like, then clearly this adult's okay. So it's a clever way to sort of build that trust, I find. I will, to a certain degree, you try and use the tools that we have as toys. So I'll give them a tongue depressor to play with. You can blow up, one of the nitrile gloves, and everyone knows how to make a chicken. I wish I had one here. This is the coolest thing I've ever seen, is if you take the middle finger and you take the knotted wrist and you pull it, you got to try this. It looks like a shark. It is the craziest thing. So just stretch the tip of the middle finger and the hand apart, and it blew my mind when I saw that. I thought, I've been doing this for like a decade, and no one's ever showed me this before. So now I do it on a regular basis, but not regular enough to have a glove here. So sorry about that. You have to try it on your own. The last thing is, kids love to have stickers too, right? So younger kids. So if your division happens to have a roll of ambulance stickers or whatever, or temporary tattoos, they love that stuff too. Obviously, these things only work for kids of a certain younger age, and it doesn't really matter, because once they get older than that, you don't really need these tools. Generally, a 7-year-old will talk to you and give you, the time of day, as opposed to a 3-year-old. Good. So those are my tips on how to make friends with kids. History taking. So we all know the sample history. I'm not going to bother going over that. The thing is, with kids, unless they are a very rare child who is not perfectly healthy, which, in Canada is certainly the minority, there's really not much on history. So by all means, do your sample history and, pay attention to the events leading up to and everything else, but you're not going to get much back. So, I think what's more relevant for kids, especially younger kids, and I'm thinking sort of, age 3 or lower, and then depending on what their presenting complaint is the birth history and that sort of thing. And so these are a bunch of questions that we don't really learn about in first aid, but is actually quite relevant in medicine. So, for the paramedics and any other healthcare professionals who are watching this, what I would typically talk about would be the history of the pregnancy, what order was this child, is this, the oldest of whatever, or the youngest, or whatever place they are, and what was the pregnancy like? Was there any gestational diabetes or preeclampsia features or whatever? Were they born at term or were they preterm? How long were they in the ICU? Were they discharged, at the same time as mom to go home, or were they kept longer than mom? And were there any problems during the birth? And that's more or less it. It kind of gives me a gestalt, and that stuff is much more relevant the younger the child is. So, routinely once kids get to sort of 4 or 5, I don't think that really plays a huge role for most of the stuff I see, but it can be quite relevant for the younger kids. So some pro tips there for the more advanced people who are watching this tonight. As I say, for MFRs, that stuff probably isn't that relevant most of the time. All right. Examination tips. Again, the vital signs are the tricky thing. And so by all means, try and get them. But if the child's freaking out as you come towards them with a blood pressure cuff, I would just let it go. Unless they're really, first of all, if the child's freaking out and able to sort of semi-protect themselves from you, they're probably not that sick to begin with. But if you have a floppy child who is staring off into space and not even noticing the blood pressure cuff, then that's the type of child who you probably want to get that blood pressure on after you've called 911. Yeah. I think that's about all I have to say about that. Otherwise, I think if you take the extra moment or two to play the games with the kids, build that rapport, they'll be much more willing to, let you feel their belly or their arm or whatever it is that they're coming to you complaining about. All right. I think that's kind of towards the end here. So let me just summarize the key points of what I've talked about here and what I would ideally like everybody to take away. And so the main thing, of course, is this pediatric assessment triangle: the appearance, the breathing, the circulation, and remembering that tickle's mnemonic for appearance. I personally find that's an invaluable tool, regardless of what level of training you're operating at, whether you're a standard first aid who is super keen, or whether you're working in an emergency department. It helps you decide very quickly, is this child sick? And i.e. you should be calling 911, or not sick. And remember, it can be done from, as we say in the hospital, from the foot of the bed, but in the ambulance, in the first aid context, it can be done from, the back door of your mobile first aid post, or, the edge. So you can just observe them interacting with their parent or their caregiver, and you can get the vast majority of information you need without even getting close. The one exception would be having the parent remove the shirt, so you can actually look for signs of accessory muscle use. But again, you don't have to be part of that. You can be, a few feet away and be able to assess that information. So again, if you're getting any concerns whatsoever, the first thing you want to do is be calling for support. You don't want to play any games if you're seeing any of these red flags come back. And I think that's sort of the one take-home point is this pediatric assessment triangle, and how it can potentially fit into your practice next time you see a child. All right, so at this point, I'm going to let Anna take over and deal with any questions that have come up. And then what I also have prepared are a bunch of little short videos of kids with various states of normalcy or pathology. So we can look at those videos together, hopefully, if my internet connection holds, and then we can talk about what the signs we're seeing are as they pertain to the pediatric assessment triangle. Okay.
All right. Thanks for that, John. We've had 2 questions pop up in the chat. The first one was about the pediatric assessment triangle. The question was that the look component seems very similar to interactiveness, and how do you differentiate between the two?
Yeah, good question. I think for younger kids, it probably is very close to the same thing. If the child you're dealing with is sort of, I don't know, maybe like 6 months or younger, there's probably not a huge difference. But once they get over 6 months, they get busy and they are now wanting to touch everything and interact with things or push things away. So they might be kicking and screaming with mommy, why are you bringing me here? I just want to go home. Or they may be, as you try and examine them, grab at your stethoscope or your tongue depressor or whatever it is, blood pressure cuff, pulse ox. And so that's where the difference comes in. Whereas the look or the gaze truly is just that portion of what are their eyes doing? What are you imagining that they're paying attention to? Are they actually looking at their environment, trying to figure out what's going on, or are they like zoned out on a different planet? Hopefully that clarifies it.
Cool. The second question was, how does the birth or pregnancy history help you assess the child? Why do we ask those questions when assessing?
Yeah, those are not binary. The answer that's given to you doesn't have a binary outcome. It's not like I'm allergic to penicillin, therefore we will avoid penicillin. It's much more, there's much more nuance to it. And so I think it's a much more advanced kind of thing. So for example, if I learn that this child has siblings and they're presenting with cold and flu symptoms, I'm going to want to know what the other siblings are having in terms of symptoms or not. If, for example, there's a suspicion of abuse, it's very important that I know how many children are out there so that, social services can be aware of that. And so it's more subtle. There's a couple of examples, but it's much more of a subtle effect in terms of just figuring out what's happening to this child at home. And then, also assessing, is there a genetic component to what we're seeing? So again, this is, well beyond what you're doing in St. John Ambulance, but these are the questions that realistically I would be looking at sort of the physician level. And so for our paramedics who are potentially taking the patients to the hospital, that's useful information to gather and pass on, I think.
Okay, awesome. Would vaccination history be relevant?
Yes, I think, again, that would be one of those nuanced things that probably isn't hugely valuable at the first aid level, but valuable to pass on to higher level of care. And, probably the most relevant thing would be tetanus, just like it is with adults. Because chances are, if somebody's coming to you with a child, it's probably not like, oh, I think they might have polio. It would probably be more like, oh, they've cut themselves or they burned themselves. And, it's worthwhile asking, is their tetanus up to date? And, referring them on for a tetanus shot. But by all means, by asking about the vaccines, that's fine. Just be aware that the vaccine schedule changes from province to province. And, a lot of what St. John sees are visitors. So, it gets very technically challenging very quickly to sort of evaluate. But tetanus, yes, no, that's more of a binary type valuable thing that could be relevant at the St. John level, I think.
Cool. So I've had no more questions in here. There's just one comment that's worth sharing. Nick says, reminder for the group that the BCEHS, so the BC Ambulance Handbook app, can be downloaded by the general public, and there's a lot of pediatric references and things that you can use even if you are not an employee of BCHS. But if you need like vital signs charts or whatever, that's a good app to use. Okay, that's it for all the questions. If anybody has any more, throw them up in here. I'll keep checking. Otherwise, we'll move into the next portion.
Okay, let me just see if I can figure out how to do this again. Okay, did you hear that little baby sigh there?
I did.
Okay, good. All right, that's a good sign. Now, how do I share my? Oh yeah, share screen, and this one. Okay. Okay. Do you see a little baby there?
Yeah.
Perfect.
Hey, pretty girl. Oh. Can you say hi? Yeah. Can you say bye-bye? Bye-bye.
Okay. Rather than turning the screen share off, I'll just leave that up. So really, at this point, when I do this presentation, I kind of open up to the group and I say, what are your thoughts on this this child? If this were a child that's kind of interacting in the chair in your first aid post, and the parent comes to you saying, yeah, do I need to be worried about this? What would your reaction be?
Quit worrying.
You want to just let people unmute themselves to discuss?
Yeah,
or?
if everyone hits unmute, I've tried doing that, but apparently it doesn't let me do the batch.
It like gives us a request to like unmute it, and then we have to give it.
Oh, okay.
Yeah.
So if y'all want to make a comment, hit unmute.
That kid looks perfectly well.
Okay. I can't hear you. Yeah. Okay. So one vote for perfectly well.
Yep.
The kid looks really well, but I don't know if my ears are like crazy, but I swear there was like some sort of like inspiration or expiratory like wheezing going on there.
Yeah, I heard that too.
Yeah, I heard that.
Okay. I think that's really the point of that video, is that the look can be deceiving, and the child definitely sounds congested. Now that child could be 100% well, essentially, from our sick versus not sick assignment, but you don't know. That child, I think, has a upper respiratory tract infection, just because of that wheezy, congested sort of sound to it. But is it something I need to be worried about or not? I don't know. I would ask the parent to take the shirt off and have a look for accessory breathing in that case, just to make sure, because that's a child who could definitely have that. And if you don't look for it, you're not going to find it. And that would be the difference. That would be the determining point for me in the hospital or wherever. Does this child need something, or can the mother be reassured, if that makes sense? So good work, everybody.
All right. We've had a question pop up related to the topic of breathing in children. Someone asked, I've heard from a few people that high flow oxygen can be harmful for pediatrics and neonates, but I haven't been able to find any stuff on it. Is this rare or old knowledge?
I think that's a question that needs to be best debated in a pediatric ICU. Anything outside of that environment, I think oxygen is good. If the child needs oxygen, they need oxygen. So, at the first aid level, at my level in an emergency department, if the child is, working to breathe, or if their saturations are not what I expect, or if you have, God forbid, like cyanosis, they need high flow oxygen for sure. And I think where the concern about too much oxygen comes in is when we just blindly give it to everybody, because it's, it used to be sort of that step in first aid where everybody gets, 10 liters of oxygen and without any thought whatsoever. So to answer that question, I would disagree with that statement unless you're discussing it in a pediatric ICU. Because again, remember that all of us are going to be with that child for a very, very finite period of time before the ambulance arrives, or before the ambulance delivers them to the hospital, or before I, in the emergency department, end up talking to an intensivist and they take over care, right? So never ever withhold oxygen would be my advice in any circumstance. But there are definitely times now where if you're looking at somebody saying, yeah, they're saturating well and they don't seem to have any lack of oxygen, where you can probably hold off. In this child, I would have no hesitation. If we lifted the shirt off and there were retractions, for sure they would oxygen. Does that answer the question?
I think so. Linda comments that oxygen is toxic and premature babies in long-term use, but not in emergency cases that we encounter.
Yeah, thank you. Because if I remember correctly, it's been a few years now, but Linda is a pediatric intensivist. So I would give her the benefit of the doubt on that one. I think it actually has to do with toxic retinopathy. So high levels of oxygen will oxidize some part of the retina. And so you can actually lead to blindness in children who are born premature. And so that's why we're very careful. And in fact, in neonatal resuscitation, which is what is kind of the standard that hospitals follow when we have a delivery, we now don't worry too much about the saturation, and hospitals are equipped with a blender so that they can actually give anywhere between, I think it's 25% to 100% oxygen. And so as the child is resuscitated after being born, there's actually a scale of, at 1 minute you're targeting an O2 SAT of whatever percentage, and at 2 minutes it goes up slightly, and so by 10 minutes you're now targeting kind of like 85 to 100% or something like that. And so as you are resuscitating this child, you actually have a shifting target in terms of what percentage of oxygen you're giving by adjusting your mix of room air versus I shouldn't say that, medical air versus oxygen. So again, we're talking about neonates who are minutes old, not children who are, going out to the fair. Hopefully you don't have anybody taking a neonate out to the fair and coming to you with respiratory problems. That would be a bad day.
Okay, I think those are all the questions for the moment. So
okay, let's go on to video number 2. All right. Flopping, vomiting child. Sick or not sick?
I say the kid looks like they're sick due to the body or the way the muscle tone.
Okay, that was a vote for sick, Martin?
Yes.
Okay, 1 vote for sick.
2 votes for sick.
2 votes for sick.
One vote for not too sick.
1 vote for not too sick, okay. Really? 3 people of like 30 are voting?
John, the video was quite jumpy on my end, so it was difficult for me to get a straight, a clear look.
Yes.
I mean, the kid seemed to be fairly upright and pink,
Yep.
which I interpret to be, along with what Mike Hoskinson just said, is maybe edging towards sick with some other indicators, but not one that I'm deathly concerned about at this moment.
Yeah.
What Nick said.
Okay. So everybody vote for sick, not sick, or what Nick said now. All right. So, and I apologize. It probably is a really crappy connection with all these videos. So maybe this exercise is not all that helpful. But this, I think, is a normal child who probably is about 4 months old and developmentally has not gotten to the point yet where they can actually sit themselves up. So are they floppy? Yes, because they're 4 months old and they don't actually have the truncal strength. But as they fall, you actually see their arms kind of move out to stabilize themselves, and the head's actually not doing too bad in that. A little bit of, spit up, that's welcome to young kids. That's a normal part of the deal for a while. And so, for a child like this, I think what would really help you to decide sick or not sick is, what are the parents telling you? Are they saying, well, actually, this child normally sits up perfectly straight and this is like they've not been able to sit up straight all day, that's concerning. Whereas if they say no, this child's just learning to sit up and this is totally fine, then I would be reassured. So in this case, I'm not super worried, but I would definitely have a listen to what the parents have to say in terms of where we're at compared to baseline. Okay, no other questions, I'll move on to next video. All right, you get the idea. Sick or not sick?
So there's like 8 people in the chat saying sick, not good, definitely sick, short of breath, labored breathing.
Yeah. I would hope that, by the time you've sort of finished your MFR and, worked with St. John Ambulance a little bit, volunteer with St. John Ambulance, you would recognize that as like somebody working to breathe. So this person needs some oxygen, maybe needs some Ventolin, assistance with their own Ventolin, needs a little PCP to come along and give them Ventolin. I'm not sure. I mean, there's a lot of information that needs to be gleaned to figure out why they're wheezy like this, but this is not normal and something needs to be done. All right, enough said.
Poor thing.
Okay, that was short and sweet. What are your thoughts on that, everybody? Would you call an ambulance or not? Is my sound off?
No, you're good. Someone
Come
is
on, everybody, take a stand.
Someone asks, is the midwife there?
Yeah, exactly. This is a newborn that just came out. I'm going to run it again in the background while we're all talking. So this is a totally normal appearing newborn. That doesn't mean they don't need resuscitation. They do. They need the assessment from what we call the NRP, the neonatal resuscitation program, to assess it. But that's a normal kind of bluish color as they come out. The umbilical cord's still attached. If you had this in your mobile first aid post, you need to call an ambulance because somebody's just delivered and somebody needs to see them. All right.
Okay, say it.
No.
All right. For me, the sound was out of sync, so I can only imagine what you guys are watching. But what do you guys think about that? Nice impressive cough in the middle of Twinkle Twinkle Little Star.
Someone says sick, someone else says not sick.
Okay. Any tiebreakers?
There's another not sick.
Okay.
Not sick, not in distress, not sick.
Okay. I agree. Again, this is somebody who I probably would take the shirt off just to make sure I'm not missing anything, just to look for retractions. But if you're able to sing, 3/4 of Twinkle Twinkle Little Star without coughing, I think that's pretty good.
Oh yeah. Yeah.
In fact, I recently heard that, and this is, this may be urban legend, but apparently when Japan, a month ago was going through the COVID thing, and they were realizing they didn't have enough tests to screen people, and people were flooding to emergency departments because they thought they had the COVID. What one of their respirologists came up with was hold your breath for 10 seconds. And if you're able to hold your breath for 10 seconds without coughing, then you don't have COVID. And I think that's a quick and dirty way to sort of assess, is there, what degree of respiratory illness do you have? So, clearly this child would be able to do that if developmentally they could actually follow that instruction. If you're able to sing Twinkle Twinkle and breathe in and out that many times without coughing, I'm reassured. I would be very surprised if we took the shirt off and found anything. However, when you're actually watching the child or anybody and they're coughing, it's very normal to see the accessory muscle use because that's what coughs are. So don't ever confuse accessory muscle use in a coughing fit with what happens when that coughing fit settles, right? So what I'm trying to say is, if they're coughing and you're seeing all these red flags and then they go away and they're actually able to breathe okay for a minute, then I don't think you need to be as worried because accessory muscle use goes hand in hand with coughing.
John, I don't have my video on here. I'm just gonna, I hate to do this to you, but I want to weigh in really fast on that holding your breath for 10 seconds thing with COVID. That was actually a viral hoax that that got spread so widely that the WHO felt the need to weigh in and directly address it.
Yeah, that's funny.
It's certainly not a bad way to necessarily assess whether someone's, acute hypoxic, but I just wanted to make sure that was, we're right up with that. It was about a month ago, actually a month ago, a couple days ago.
Yeah. No, I believe it, but whoever came up with it, like, it's not a dumb hoax. Like, I think there actually probably is a certain degree of value to it. I certainly think, and again, this is anecdotal based on my experience, but when I think about it, of all the people that I've seen over the years with respiratory stuff in emergency, I'm dying, doctor, help me. If somebody can actually hold their breath and not have to breathe or can, suppress a cough for 10 seconds, like, to me, that's a pretty reasonable, quick and dirty thing. So regardless of where the source was, I think there's actually some wisdom behind that. Not that I'm saying we should be using that for, COVID screening or anything like that. I don't mean to politicalize this evening about that, but yeah, it's interesting that the source is different, but I still think there is some sense behind that.
I think the from what I can gather, I just refreshing my memory on this as we were chatting here. I think that the difference is that the meme that was being shared about this was suggesting you could diagnose yourself as whether or not you were a carrier of the virus, as opposed to suffering from acute respiratory distress secondary to the disease. And
gotcha.
The issue is that if you can hold your breath for 10 seconds, not only are you not acutely hypoxic, but you're also not a risk to anyone else, and so you can go about your day.
That's right.
That was
gotcha. Gotcha. Okay. Yeah.
But
so you see the spiral of the internet. Yeah, I understand.
The acute shortness of breath. It's absolutely a reasonable clinical assessment. But
yeah.
But no.
Okay. No, fair enough. All right. I certainly can't support that claim. I've heard that actually, if you can hold your breath for 10 seconds, it makes you more virile as well. I think you're a lot more manly if you can do that. Anyway. All right. So let's get on with the next one.
I'm right here. It's okay, Xavier. It's all right. Yeah, Daddy's here, Xavier. It's okay. It's okay, Xavier. It's okay. sweetheart. Oh, God. Oh, okay.
All right, I can hear somebody typing. So they're brave enough to put a text response in, but not brave enough to pipe up. Sick or not sick?
There's a few comments here. One is ALS, please.
Okay.
Lots of people are wondering if that's a seizure.
Yeah.
Difficulty breathing. Everyone else is pretty well saying sick.
Yeah. Yeah. Okay. That's kind of a half and half one. Yes, I think outside of the emergency department, that kid's sick. In the emergency department, I'm not worried about that. That's a febrile seizure. And I mean, almost certainly I'd have to confirm that with the history and the temperature and whatnot. But that is a child who I suspect has an upper respiratory something or other going on, very high fever, which is very common. And I'm confident saying that because when the seizure breaks and he starts blinking, you can actually see the cough of the upper respiratory grossness come out. So that's why I'm thinking that's the etiology of that. And so febrile seizures are actually benign. Now you have to there's a bunch of criteria you have to apply to it. It has to be linked to a high temperature. It can only go for a certain period of time. There's no postictal phase. So a bunch of technical stuff that I would not recommend anybody outside of the emergency department make a diagnosis on or a call on. But honestly, I think at the end of the day, that child will probably be okay. I would be very surprised if there's anything more complicated than that going on. Yeah. And so what I would expect now is for them to sort of wake up and be hot and kind of miserable and cry for a bit. And then parents would scoop them up and they would, their consolability would be fine. They would settle down and they would show up to emergency, 20 minutes later. And by the time I see them, I get this very dramatic story about what happened. But in actual fact, I think the prognosis is very, very good for that child. If you have a febrile seizure, you're very unlikely to have any other seizure issues as an adult. You are more likely to have another febrile seizure at some point, but they're not particularly dangerous things. However, there are red flags, so be cautious about, trying to do more than you're trained to do and make a call on that. Okay, any thoughts on that?
There's a question here. Might this be a first seizure? Would it then be more of a concern?
Mm-hmm. Yep, it would be for sure. And that's why in the hospital, we would, figure out what the timing is and what the pattern is and everything else that's going on. And there are definitely flags to help tease out a real seizure from a febrile seizure for sure. So that's why I think it's important that this child goes to emergency because, even though it's a low chance that this is a real seizure, it's high consequence. So it's important that they get that diagnosis as early as possible so that they can get the appropriate therapy as early as possible. Yeah, good point.
So question here is, what do we do if a patient has a febrile seizure in the field?
You do exactly the same thing you would do for a regular seizure. So you get a bite block. No, I'm kidding. You basically just do supportive stuff. You can call 911 for sure. You can get a blanket. You can just kind of protect them. Febrile seizure by definition lasts 90 seconds or less. And so you can do a little bit of blow-by oxygen, but honestly, by the time you get that set up, probably the seizure has broken. And I would also probably take the lead from the parents as well, because if the parents are saying, yeah, this has been going on and I'm not worried because, X, Y, Z, then okay, that's their call. But I think most parents would be having a little meltdown at that point because most parents are not familiar with the nuances of febrile seizures. So, yeah.
And Linda says, try and lower the temperature with some cold towels.
Yeah, yep. So that's a reasonable thing to do. We don't give any medications as MFRs other than ASA, I believe. Am I correct in that?
Yeah, ASA and glucogel and oxygen.
Yeah, okay. Yeah. Okay. So oxygen here, the parents can certainly give some Tylenol or some ibuprofen or something like that, which would be very reasonable as well. And you can certainly try and cool a child down if you're worried about that. I'm not up on the literature in terms of cooling. It's certainly not a huge priority for us to try and mechanically cool them by using cold cloths or whatnot, because we have medications and things that are more effective in the hospital. But I'm not totally up on febrile seizure literature, so that may be a recommendation. Good. Any other thoughts, or shall I play another one?
So next question is, if a febrile seizure isn't a life-threatening condition, why cool the child when we've called an ambulance?
Yeah, I think it's going to be difficult to cool them as well, to be honest. I probably, I probably would not, because you don't want to overcool them. And it's very difficult to regulate the temperature, because to really truly understand what their temperature is, you need an internal temperature, like a rectal temperature or whatever, which I don't think we've released the module on that yet for St. John. And so you don't know what you're targeting. So probably a better way would be just to take some clothes off, put them in a cool shaded area kind of thing, as opposed to put cold packs on them or anything like that. This is not heat stroke. This is a reaction to the fact that they have a fever, and it's part of the normal process of fighting the virus or whatever the pathogen is. So I would, at the St. John level, I would be cautious about trying to cool them. I wouldn't recommend that, I don't think. I'd have to do some reading to find some evidence to suggest that it's actually valuable to cool in the field, other than what I described, like put them in the shade and take excess clothes off and things like that. Yeah.
Yeah, and Linda just notes, no aspirin, please.
No aspirin, yes. Yeah, that's right.
Rosalie, I see you've put your hand up. I'm going to mute you because I'm not sure if you have a question.
Is that a question or hitchhiking home?
You good? Okay. She's muted herself. Okay.
I think it was a thumbs up. I think she's trying to hitchhike.
It might have been a thumbs up, yeah.
Okay, cool. Now, I realize that we are at the hour mark, and so obviously if anybody watching wants to drop out and are getting bored with this, that's totally fine. I won't be offended. But I have, another 5 videos, so I'm happy to run this out and do whatever other discussion there is. I'm not sure what the actual time frame is on this, but I realize people have lives, so I will not be offended if people tune out here. And I do think that this is being recorded as well. So, if you have nothing better to do and can't find anything on Netflix, then you can always watch this again. So, there you go. All right, let's look at this one. Okay. Any thoughts on that?
People are saying this child looks flushed, lethargic, sick. They're asking if this is a seizure.
Mm-hmm. Yeah, this is a focal seizure that is affecting the right side of the brain. And it's really just affecting the, you can just see the movement in the left side of the body. And then also the fact that the eyes deviate to the left are the giveaway that the seizures in the right. It looks a lot like the baby's looking at mom, but the baby's too young for that. And so it just happens to be the way she's being held. So this is a focal seizure, which is not benign. At least it's very difficult to know if that's benign. That's outside of my pay grade. And so this is somebody who needs to seek medical attention. Now, in terms of how urgently, do you need to turn your lights and sirens on, paramedics? I think it really depends on the stability of the child. So sure, maybe a little bit flushed, but what's the saturation doing, and especially once the seizure's broken, which we saw at the end of the video there. And so, if they're hemodynamically stable, I think it would be fine for them to go in routinely, or even the parents could, potentially drive the child in if they're, seem to have some insight and are not panicked about this. Don't want panicked parents trying to drive up the meridian to get to the hospital in time. So, this is somebody who needs to be seen by a neurologist, but, it's not a time sensitive thing, if that makes sense. Okay.
Question that's popped up, not totally related to seizures, but someone says, I've understood that skin blanching or cap refill is acceptable in a child in lieu of a blood pressure as a check of adequate circulation.
Yeah. Cap refill is valuable. It's not as valuable as a blood pressure, but again, getting a blood pressure in a infant is very challenging too. So I wouldn't waste a lot of time trying to get a blood pressure if it's not coming easily, and documenting the cap refill is totally reasonable. But just be aware there are lots of pitfalls with it. Dead people have a cap refill, so it's not really a vital sign, but definitely a reasonable thing to check and document if you know how to do that.
Comment here is, I'd worry about parents transporting this child with the possibility of a second seizure event.
Yeah, very, very reasonable. I think it depends on the parents. If the parents are ICU staff, then that's one thing. Whereas if they're kind of panicked lay people, then I agree. Probably big difference in who's driving their child there. So I would sort of do it on a case by case basis. Yeah, but an ambulance would be more than reasonable to call for that in this case.
That kid needs a full workup, and even if they keep seizing or have another seizure on the way, there's not going to be much that anybody's going to do.
Yeah,
I don't really see transport by the parents being a problem unless they're totally freaking out and likely to get into an accident.
Yeah,
I think the thing is, and maybe I've had one of these go bad on me actually just a couple of months ago, so maybe I'm more responding from an emotional response there, but it depends. If it's just a febrile seizure and there's a second febrile seizure that lasts 30 seconds while en route, well, what do you do? It's a benign event. They get to the emergency department. There's no problem. If it's a seizure that's resulting from another pathology, whether it's a tumor or whether it's a meningitis or something else that one of the million other things that causes seizures. If the kid has a second, third, or fourth seizure and one of them turns into a status event, you've got parents, whether they're ICU trained or not, with a kid having a status seizure in a car, that's a problem. And that would be my, coming strictly from an ambulance point of view, I'd be very cautious about that unless you were really, really, really sure that it was just a straight febrile event. Then, and obviously case by case and all that, but.
Sean, this is not going to be a febrile seizure, right?
It didn't look like a febrile seizure to me. No, because it was a unilateral thing. It was only the right side motor cortex that was involved, because you're not seeing activity on both sides. You're only seeing activity on one side of the body. So I would be shocked if this were diagnosed as a febrile seizure. I think this is a focal seizure. Yeah,
some kind of a brain lesion, like a
brain lesion or epilepsy, or as Nick says, it's a long list, right? So,
yeah. That's why they have neurologists and
MRIs. That's how I feel.
EEGs.
You're on my level.
We used to do not for kids this young, but we used to do SPECT scans for seizures in slightly older kids in Edmonton. But they were on constant monitoring and people running in to inject the tracer when while they were having the seizure, that sort of thing.
Totally.
For partial complex seizures.
Yeah. Yeah. You know, these things can be very difficult to tease out. So definitely needs medical support. You know, it's very reasonable to call an ambulance in this case, you know, especially if the parents are not dead opposed to it. I would just do that. Yeah.
I'd like to hear from Nick. What was the situation where things went south?
I'm going to think about how I can answer this while respecting confidentiality, because it's probably a fairly unique thought. It was a young child who was about 18 months, give or take, who had what was initially presumed to be a febrile seizure, and later turned out, I found out, to actually be a brain lesion. And he'd had it was a cancer of some variety, I don't recall what. But he'd had one seizure in a public place, and had been quite warm because he'd been out in the sun, and you know, and we actually showed up, and there was debate about, like, well, it probably looks like a febrile seizure, and it does, you know, he's a little bit warm to the touch, and we struggled to get an accurate temperature because we can't do core temperatures, of course, but it's like, he feels a little bit warm. And then about 3 minutes into transport, I was very lucky. I had one of our ALS members with me in the vehicle, but he actually went into a status seizure that then lasted until the seizure was broken pharmacologically, and we ended up ventilating the kid for about 5 minutes on the way into the peds trauma bay. So I'm a little bit punchy about things that can be presumed to be or thought to be benign or transportable by parents. In my world, people who have seizures, whether they're adults or kids, should be presumed to have another one coming soon, and be taken to hospital in a way that provides them with the potential for maximum support if it's necessary. But I've seen adults do the same thing. You know, certainly not the norm, but certainly some varieties in adults, some varieties of epilepsy, or some people are prone to repeat or cluster seizures, which can be equally problematic as well. So,
yeah.
I made a home visit one time in Port Simpson years ago, just north of Prince Rupert. I was the doctor there, and the woman was young woman in status epilepticus. I gave her a bolus of diazepam, and she immediately stopped breathing. So naturally, I asked the nurse to go and get the bag of BBM. But meanwhile, all I could do was do mouth to mouth. This was before they had any diseases. It was that long ago.
Wow.
It was kind of funny in a way, because you know, it was pretty obvious that she was just plain not breathing, and everything else was stable. So the nurse came down within a couple of minutes with the bag, and I was bagging her. But meanwhile, the entire village showed up. You know, the older women and middle-aged women, and a couple of them walked through the room and said, "Why don't they send her to Rupert?" And I said, "I heard that." I said, "Tell you what, if we call in for a helicopter, and you know, we transport her in the dark with the helicopter bonking around, it's going to be hard to keep her you know, breathing properly. In 10 minutes, she's going to wake up, and she's going to ask for a cup of tea. So why don't you go into the kitchen and make some tea?" And sure enough, 10 minutes later, she woke up. She said, "Oh, cold." I said, "Ask for some tea." That's my story. I'm sticking to it.
That's good. Yeah, all right. Fair enough. Things have changed a bit. All right, well, let's have a look at another video. Let's take a look at this Strider one. All right. What do we think about that?
All right. Comments. Somewhat sick. Sick, noisy breathing. This is an ambulance call. Couple more sick. And then one not sick.
Yeah, I agree with everybody. I think if I were seeing this, at an event for sure, I'd be referring that on. It needs to be evaluated further. I think there was maybe like a little bit of trace accessory muscle use kind of in the neck there, just supraclavicular. It's hard to tell because that's a chubby little baby. And then the abdominal breathing was like a little bit going there. So that's somebody I'd watch a little bit in an emergency, but potentially I might end up discharging home too. I'd need more information on that one. So I'm on the fence myself. Yeah. But for sure, if you're at a St. John duty, I think that one needs to go. Yeah. Good. Let's take a look at this one. Run that again. Just look kind of down here. So hopefully you can kind of appreciate in the abdomen here that there's a little bit of like accessory muscle work going on there in a very young child. I mean, this child's probably, like less than maybe about a month old, less than a month old. The umbilical cord still looks fresh there. So what does the survey say?
Survey says, yikes.
Yeah.
Survey says sick, the giveaway, the monitor alarming in the background. Sick, respiratory distress.
Yeah. Very clever with a monitor comment, except that that is probably not the only patient in there. So that might be someone else's monitor. If you've ever been to emergency, you can never tell which monitor is dinging. So nice try. But yeah, no, I agree this person's sick. And if you're seeing that out in the field somewhere, they need to go. All right, good. What else we got? Getting down to the end here. Another subcostal retraction. Oh yeah, that's pretty dramatic.
Having pretty rapid retraction. And he's desatting. He wants to pick up his own so I can get that. Yeah, see that. He's just all around not a happy kid.
So these are parents of a medicalized child because they know some of the lingo. They clearly have stuff going on. Looks like he's got an IV in his arm because it's all bandaged up so it doesn't get pulled out. They have a SAP monitor. And so you can see in this one the difference between parents who have insight and know what's going on versus somebody who's, has never seen this before and panicking. Anything else coming up in the comments there?
Just that the child is very sick.
Yeah, for sure. That's not someone you want to be monitoring, managing in your first aid post.
Yeah.
All right. Sorry, someone else? Nope. Okay. All right. And then the last one is the seizure video, which has nothing to do with kids, but it's going to demonstrate a seizure. And if I remember correctly, it's got the Jacksonian march where it starts in one part of the body and then it progresses. So he stops, and then you're gonna get the epileptic cry.
It makes all kinds of
And then the rest of the body gets involved. There's the tetany, so that's the tonic part of a tonic-clonic seizure. I would not be putting nasal prongs on him. I'd be putting an oxygen mask on him. It's a lot easier. There's the clonic phase. lots of rhythmic motion. You can see it's both sides of the body. This is a grand mal seizure with all the classic findings.
He does. Okay. Yeah. Okay.
I would not be putting suction in his mouth.
Okay.
Have the suction ready to go, but don't put it in while he's still spasming. That's how you break teeth. All right, that's enough of that. Any discussion on that one?
Question is, what is Jacksonian March?
So Jacksonian March is where the seizure activity starts in one part of the brain and then it travels around the rest of the brain. And that manifests itself by seeing one part of the body start and then the spasms actually progress to the rest of the body. So if you watch that video again, and I'll turn off the sound because it's a little bit impressive. If you watch it again, he's going to start kind of in his right arm and his neck, his muscles in the trapezius is going to bring his neck around to the right, and then he's going to give his yell, and then the rest of the body, can you guys see my pointer? The rest of his body is going to begin to get involved as well. So there he stopped. So now something's going on. And now we get the right upper quadrant first. And that's the Jacksonian March, where it starts in one part and then the rest of the body gets involved. And there we go. Everything goes into spasm. Yeah. This is like a textbook grand mal or tonic-clonic seizure. Any other comments on that?
Linda comments, the caregiver should place the head on the side, so I guess in like lateral position, while seizing to avoid aspiration.
Yeah, I agree. So the concern is that he's going to reflux up his Big Mac and then get it down into his lungs. And so, you know, absolutely right. You know, what first aid teaches us is protect the patient. Now this guy's in some sort of seizure precaution thing with all the pads on the bed already. But I agree, first aid wise, you clear all the things around him so he's not going to bang himself into anything, and then try and get him up on a side if at all possible, so that if he does vomit, gravity will help you out, as opposed to sticking something in his mouth. That's pretty bold.
Nick says this is a really good example of why, if you have a patient who is seized and is now on your stretcher, you should do up all the seat belts and buckles.
Yeah. Yeah.
And maybe
sure.
drop the stretcher down a little bit so it's not full height.
For sure, right? Center of gravity on the main cots that we use, you know, in ambulance and in St. John, like it's tippy when you're up high. And so by dropping it down to a lower setting, I think you would definitely protect against that, you know, or at least make sure you're stabilizing it so that, you know, you don't end up going over on the side. Good. Well, I think that's my video collection for tonight. I don't want to take too much time here. So any other thoughts or discussion or?
There's a question, why would you even try to give oxygen during a seizure?
Because believe it or not, the oxygen actually gets down into the lungs, even if they're not breathing. High flow oxygen will actually diffuse its way down. There's this video in anesthesiology that blows my mind, and they have these OptiFlow, which is kind of like nasal prong on steroids. It blows 70 liters per minute through the nasal prong, and they are doing some sort of airway surgery on the patient, and they paralyze the patient so the patient cannot breathe. And for like 25, 30 minutes, they're doing this surgery, and the person's saturations are 100%. So the volume of air, of oxygen being blown into the lungs is sufficient to keep their saturations high, even though they haven't breathed for 30 minutes. Like it's mind-boggling to me. And so, you know, obviously we don't have OptiFlow, but if you put nasal cannula on or a high flow oxygen mask or a non-rebreather or anything, and you crank it up to whatever your tank goes to, 15 or 25 liters per minute, some of those oxygen molecules will be getting into the lungs, and that's better than nothing. So that would be my answer to that. it seems counterintuitive, but it really does make a difference, albeit a small one. Yeah.
All right, I have no questions popping up. Oh, wait, here's someone. No, not a question.
All right.
All right. Does anybody have anything else they'd like to ask?
Yes.
Go for it, Rosalie.
All right. Can you hear me?
Yep.
Okay. Thanks, John. I was wondering, when you say for taking the shirt off to see accessory muscle during breathing, do you actually have to take the shirt off, or can you do it by auscultation?
No, I take the shirt off because what I'm looking for, I know air is going in and out, and that's what auscultation tells me, is that air is going in and out. What I want to know is, how is the air managing to go in and out? Are they having to use all of their, intercostal muscles in the ribs? Are they actually getting the indrawing above the clavicles or the abdomen? And so by removing the shirt, or even just lifting it up, you can see all of those muscles and whether they're working or not. The last couple of videos with the kids breathing, where you could see kind of that subcostal retraction, I think that kind of highlights the sort of subtlety that you might not see if they're wearing, a little onesie or their t-shirt or whatever. So.
Cool. No questions, but if you open up your chat, John, there's a bunch of people saying thank you for this.
Okay. All right. Yeah, my pleasure. It's been fun. Good.
All right.
Well, if anything does come up, you guys know how to get a hold of me, or if you don't know how to get a hold of me, just talk to Anna. She knows how to get a hold of me.
Yeah, absolutely. So people are asking if we're coming back next week. We are. We will be sending out the link again to the Island Division, so stay tuned for that. Ross says, great to see you again, John. But yeah, thank you so much for your time, John. We always love having you come teach us.
My pleasure.
And as mentioned earlier, this one was recorded, so we will post these videos once we sort ourselves out with that. Next week, we have Nick talking. Nick, do you want to present? Do you want to talk about what you're doing next week?
Yeah, sure. Let me just turn my camera on so people can start video. Everyone see me?
Yeah.
Oh, fantastic. So next week, as most of you guys know, I'm a bit of a history nerd. So I'll be talking a little bit. It might not be a full hour presentation. I'm not sure. It'll depend on how much I can put together. But I'll be doing a section on the history of the Order of St. John, sort of taking us from some of our deeper historical roots up to the present day, and discussing what we do in different parts of the world. And how we got to how we as an organization got to where we are today and stuff. So if you like that sort of stuff, tune in. If you don't, come back the week after for whatever we're teaching that week.
Yeah, so we do plan on going every Monday until this whole pandemic thing quiets down and we can start meeting in person again. And until that time, we'll be sending out meeting invitations to all the divisions that we can. So stay tuned for those. Did I just freeze, or did everyone freeze?
None of the above.
Okay. Nick's screen just froze, so I wasn't sure if everything did. Okay. And on that note, if nobody else has any questions, I think we'll...
Quick question.
Austin, go for it.
Yeah, hi. So I know you were in talks with the Canadian Blood Services about that thing. I haven't seen any kind of further updates yet on it. Like, do you have any more updates like right now, or should we just wait for like the next email to commence?
Yeah, so it's still kind of in talks. There's a bunch of organization happening at the PHQ level. At the divisional level here in Victoria, we have told them we would be helping. What that exactly means right now, I don't have an answer for. so there's the blood services, and then the second one we're doing is the first aid at the tent city. So if people are interested in that, get in touch with me. We're kind of there every day. We're trying to figure out what the best times and days for us to be there will be. But we do have a few things in the works for you guys to keep you busy while we're in this period. Does that answer your question?
Yeah, totally. Thank you so much.
Okay. Ross says Topaz Park, we're currently there every day 9 till noon. So if you are interested, there's a few extra things, some safety training and such that you need to undergo, but Ross is kind of the guy that's organizing this whole thing. All right, does anybody have anything else? If not, stay tuned for the invite for next week. And I hope you guys have a good rest of your evening and stay safe, stay healthy.
Thanks, Anna.
Thanks. Take care, guys. I'll end this meeting if nobody has anything.
Well done.
You.
Good job.
Good night.
Thank you.